Hello, everybody, and thank you for joining us for our final webinar in our Learning and Action Network here of diabetes and COVID-19. Today, we're going to be focusing on communication with patients. Thank you for your participation today and on any previous sessions that you may have attended. We appreciate your ideas and feedback this far, and we will be reviewing some of that later today. So please hang with us through the end of this session. Next slide, please. We have our same objectives here. We've all seen them, so I'm not going to go through those. So if we move to the next slide, we can hop right into our COVID-19 regional updates. As we all know, COVID-19 is continuing to spike throughout the United States. We are anxiously awaiting to see how good of a job we did staying home and social distancing, physical distancing during the Thanksgiving holidays. Hopefully we will see that most people were able to fall in line with those guidelines. They were able to do virtual get-togethers with family rather than in person. So here in the next 2 to 4 weeks, we'll get to see how well that went just in time for the Christmas holiday. Next slide, please. Moving into our state updates, state and territory updates, there's some pieces of good news and then some interesting things happening sort of as you dig further into the data. So we're going to talk about that. As we start off with Alaska, you can see that our total number of new cases is down. I was talking to a colleague earlier today, and as I visit these state websites and look at their information systems, you can really see public health evolving as we learn how we're going to grapple with this pandemic. And so there's fluctuating data available. So you'll see that we don't have active cases available for Alaska. We're finding that that isn't necessarily a very important metric to monitor anymore while we have such widespread community transmission. So that has been dropped from some of our reports, but we are starting to really focus heavily on things like hospitalizations. So Alaska was previously reporting cumulative hospitalizations. Now they are reporting daily census. So that 144 you see there is a daily census. Some important things are happening inside of that hospital utilization. Alaska has 3.7% of their COVID hospital patients currently on a ventilator. So they are so ill, they are requiring that level of care. 59% of their available non-ICU beds are being utilized at this time, and they have fewer than 24% of their ICU beds available. So lots of important things to keep an eye on. That 24% ICU bed reflects COVID and non-COVID patients, because as we all know, illnesses are not stopping just because we are in a pandemic. When you look at Guam, Guam has really been struggling with, stay on that same slide for me, please, has been struggling with an outbreak right now, but they are have been able to really lock down, encourage good infection prevention, and they are seeing hopefully the tail end of that spike. We are seeing new cases dramatically decrease, active cases are decreasing, hospitalization use is really down, much more manageable now. They're getting a nice reprieve over there. And they've increased testing so that their 7-day testing average is able to decrease as well. So getting a much better handle on what is currently going on so that they can reduce community transition. Next slide, please. Same story with Hawaii. Hawaii, as we've talked about lots of times, in August and September, really return to stringent physical distancing, good mask wearing, and they are seeing their caseload really drop. They have flattened their curve there again. We are seeing per capita very low rates of new cases, low rates of transmission, very limited community transmission there. So we are still seeing some uptick in deaths. Unfortunately, there's a big lag between disease onset and outcomes. That's something that we'll talk about more as we get more data, but the sequela that comes along with COVID-19 can include things like liver and kidney failure, vasculitis, long-term lung injury. And so we do see that death rate sort of tick slower behind, but overall good news in Hawaii. Montana is starting to improve slowly. We're seeing their 7-day testing average come down, again, because of increased testing, better contact tracing. Hospitalizations are improved over 2 weeks ago, but still very high. Our number of new and active cases is also remaining high. More work to be done there. We are starting to see some county-wide mask mandates in Montana and Wyoming, which will hopefully help these numbers, but definitely not time to say we're out of the woods there yet. Next slide, please. Northern Mariana Islands are still one of our bright spots, along with American Samoa, who is never going to make our list, hopefully, knock on wood. They have had a couple of new cases in the past couple of weeks, likely due to travel, but are doing a good job maintaining their strict quarantine protocols as people come onto the island, so keeping the number of cases in the community very, very low. Wyoming is still continuing to see their acceleration of new cases. Currently today, 1.5% of the population in Wyoming has an active infection, and 5.75% of the total state, remember this is our least populous state in the United States, has been infected with COVID-19 and has been confirmed through testing. More than 3/5 of those infections have occurred just in the last month. So we know that the physical distancing protocols there are not being followed strict enough to reduce the rate of transmission. Again, we're seeing a lot of county level mask mandates, returns to stricter physical distancing protocols to help slow that. Deaths are definitely accelerating in Wyoming. Hospital utilization, again, are very, very high. 56% of ICU beds in Wyoming are currently being utilized. One bright spot for them is the testing has really dramatically increased. So remember last time we met, 66% of tests in Wyoming were positive. Today, it's down to 9.49%. That is directly related to increase in testing. So we were testing 2 people per every 1,000. Now we're testing 10 people for every 1,000. So that really improves our ability to quarantine people who could be asymptomatic carriers, reduce community transmission, and practice good quarantine protocols to slow the rate of transmission. Next slide, please. Here's our apples to apples. You'll see there are a lot more green arrows this time, indicating a decrease in our rates, decreased transmission. There has been really good messaging nationwide around the need to really buckle down, return to some of our physical distancing best practices, and we are seeing the fruits of that labor. We're also seeing we had a spike that would naturally happen after everyone went out at Halloween. We are through that new infection onset that would come with exposure around Halloween. And so this is sort of the lull before we start seeing impacts from Thanksgiving leading into Christmas. So again, like I said, definitely not out of the woods, definitely still time to buckle down, encourage good infection control, encourage mask utilization in places like Hawaii and Guam, where they do have more mask mandates and they are having better public perception around masking. We are seeing that it is reducing transmission in those communities. So lots of evidence to support the use of masks. And then important things are happening in the COVID-19 vaccine world right now. Both the Moderna NIH-sponsored vaccine and the Pfizer vaccine have been submitted to the FDA for emergency use authorizations. Pfizer announced last week that they were doing a dry run of their distribution. That went well. They now have vaccine widely available throughout the United States, ready to be released once that emergency use authorization is granted. If that goes as planned, that will likely happen on or around December 11th, so next week. These are the vaccines. Those are both the mRNA vaccines, so they are requiring very cold storage, like -70 degrees is bantered around, so it requires a super freezer. Many hospitals have been contacted requesting that they get those freezers. They have the ability to be distribution centers. So hospitals and public health facilities in most states are going to be the first distributors for that vaccine. It will be offered to healthcare professionals first, as well as professionals working in long-term care facilities and then long-term care facility residents. That's obviously because of the very high risk of adverse events should they contract COVID-19. And also we can't afford to have our workforce be down with COVID-19. So we're still waiting to hear about AstraZeneca's vaccine, which does not have those cold storage requirements in the United States. But I'm sure that they will be rushing to the market as well. Because they don't require the same cold storage, there is better access, possibly. We're not going to need the same equipment to have that. On the back side of that, there will be lots of information coming out. It's looking like we can cold store those vaccines for about 30 days on dry ice if you're not able to get a super freezer. So the next few weeks will probably be very fast and furious as far as who will get vaccine, when the vaccine will come, what that distribution will look like. But 14 days post-vaccination, if you're getting the mRNA, so Moderna or Pfizer's vaccine, you have greater than 90% coverage. Most of those are going to be a two-step vaccine. So we'll give one and a month later, you'll get another one. That helps boost the efficacy. So once you complete your full course of vaccine, you're looking to have between 90 and 95% effectiveness, which is phenomenal, like mind-blowing effectiveness for a vaccine. Truly historic times. Yep, and like Kyla says in the chat, it looks like they are starting to test how stable it will be at refrigerated temperatures. So I do suspect that we will learn more about that, and it will get easier as we move through. But likely, we will start seeing healthcare providers and long-term care residents being protected from COVID-19 infection by early January, which we can all celebrate that. It's really going to help bring these numbers down rapidly. And I personally am very excited about that. So Mountain Pacific is working on some of our tools and resources around these vaccines, so more to come on that in the future. That's all I have on COVID-19. If we can move to the next slide, please. So it is still flu season. So before I leave you today, I just wanted to touch base about influenza. We are seeing some fluctuation with flu in the United States. Iowa was previously having some high to very high activity that has decreased, but we are really starting to see our normal ebb and flow of influenza. So definitely we'll need to keep that in mind as well, particularly as the vaccine for COVID-19 starts rolling out and we reduce our physical distancing requests and requirements of people. We will see flu likely spike. It is definitely a lower start to our flu season than we have had probably in the past decade when we've really monitored closely. But as we start letting people move back into the community, we should expect to see that as well. Our initial high spikes were tied to influenza B. Now we are seeing influenza A circulating a little bit more often. Like I said, probably not as much as we would expect for this time of year, but definitely something to still keep an eye on. With that, I'm going to turn things over to my colleague, Kyla.
Thank you, Stevie. So I'm going to talk a little bit today about communicating with patients about chronic disease specifically diabetes, and how it's really a process. It's not just, they get dropped with the diagnosis, and then they also get tons and tons of information. They are most likely overwhelmed. They might have misconceptions. They may have different emotions based on what their previous knowledge or experience with diabetes is. And it being such a comprehensive disease anyways, affecting pretty much all areas of the body, it's important to use effective techniques to communicate with patients, and also to keep their top priorities in mind as we develop care plans and use shared decision making and set goals for management of their disease. Next slide, please. So typically, if we look at some of the literature, patients retain about half of what they hear. And so I looked at one particular study here that mirrored that. It showed that without prompting, patients retained about 49% of information that they were given. The method they used for this was they did a follow-up 7 days after the patients had received the initial information. If they were given some prompts or reminders, they were a lot higher percentage. An additional 36% was information was recalled. So that's still only about 85%. So it's really important to keep in mind how much they're remembering, and understanding that we almost have to take a step back and say, okay, we want them to be adherent, we want them to follow the care plan, but first they kind of have to have this base level of knowledge. And so that just incorporates into our diabetes education as a continual process. Next slide, please. So the ADCES, which used to be the AADE, and the American Diabetes Association have some really good resources for guiding us on how to communicate with patients and what language to use when we're communicating with patients about diabetes. And there's a report, and I thought there was a link on this slide, but there will be links when we distribute the slide set. Actually, I think it's on the next slide. But there's a report, and then there's like a 2-page handout that kind of outlines their guiding principles and philosophies as far as when we're communicating with patients. Oh, thank you, Patty, for putting that in the chat. So the language we use is just as important as the information that we're communicating. So it's important to keep that in mind. And the recommendations are for use by healthcare professionals when speaking not only to patients, but colleagues or the general public. Next slide, please. So these are just some techniques that you can use as far as when you're speaking with patients. We've probably all heard or know about some of the stigma surrounding when you get diagnosed with any chronic disease, but specifically diabetes. Just making sure that the patient is the kind of the center of your discussion, using a shared decision making, and make sure that you're using person-centered language, which I will talk about on the next slide, please. So this is the, I think it's a 2-page handout. That's really nice. That kind of gives you some of the typical language that we've used behind persons with diabetes, which is the more preferred verbiage. And some of the top points that they talk about are using patient-centered instead of disease-centered language, focusing more on pathophysiology and physiology, using terms like manage instead of control, making them more patient-focused. And when we talk about medication adherence or adherence to a treatment plan, we should use words more like participation and involvement to make sure that they're more patient-focused. Next slide, please. So here are all of the things that we are presenting to a patient, all the things that in the process of their diabetes education. So this is a lot of stuff. And as I said before, diabetes means such a multifactorial, multi-organ disease. It's even overwhelming to us when we look at presenting this information to patients. So it's really a process of saying, hey, here's the things that we need to look at or that we need to discuss, that we need to manage your disease, and coming to that agreement with the patient on really what things are we going to focus on. And obviously some of these are, more patient specific, like the insulin and the pain management, but they're all important things to consider. Next slide, please. So these are just some best practices. These are very general, but these are things that Mountain Pacific is available to help facilities work on and kind of explore and do more of a deeper dive for their patients. And we're going to be doing some polling at the end where you will be able to give us some feedback on what you would like to see from us in the future as far as support for these best practices. So next we're going to do kind of a mock patient scenario, and then we would like to get your feedback on how you think a conversation with Sally and her healthcare provider went. So Stevie's going to be the patient and I will be the provider. Hi, Sally. I was looking at your blood work and I wanted to schedule some time to talk with you about your results. Your blood sugar and hemoglobin A1C are elevated.
Oh, geez. What does that even mean? I mean, blood sugar, does that mean I have to give myself shots? My sister has to give herself shots. Can I just stop eating candy and drinking soda? Like, I probably just have had too much sugar.
No, you're not going to have to give yourself shots. We'll talk more about the treatment. But first, I want to let you know what having high blood sugar means. It means that your body is not absorbing the food you eat correctly, specifically the component called carbohydrates. We use a test called hemoglobin A1C to see the average blood sugar over your past 3 months. Both your fasting blood sugar and your hemoglobin C are out of range.
Out of range? So like,
they're higher than we want them to be.
So I have high sugars, so I have diabetes.
Yes, and I would like to start treating you for diabetes. I would like you to start taking a medicine, and I also have some other things that I would like you to work on, including dietary changes, weight loss, and exercise. These things, along with the medicine, can help to manage diabetes. There are a few side effects I want to warn you about the medicine. It can cause nausea or just feeling sick to your stomach, diarrhea, and sometimes weight loss.
So I have diabetes, but the medicine you'll give me will cause me to lose weight. So, woo, I've been trying to lose weight for years.
Yes, this is a beneficial side effect. I also wanted to talk to you about your activity. Do you exercise?
I mean, I walk my dog, like around the block a couple of times a day.
Okay, that's good. There is a recommendation that for everybody that they get about 30 minutes per day of physical activity, including walking. It doesn't have to be anything super cardiovascular or super strenuous. But do you think that you might be able to start walking a bit further every day?
Yeah, I think I could try that.
Okay. And how is your diet? What do you eat most of the time for a typical day?
I think I do pretty good. I'm not a big breakfast fan, but I really like fruits. So I'm eating a lot of fruit. I don't know. I think I do okay with my portions. But I really have a sweet tooth. So I do like, I have like emergency chocolate and things like that around the house. I really like sweet things.
Okay, well, that's something that you can talk more with our, we have a person at our clinic who does diabetes education, and I would like you to go see that person, and they will share with you what a good diet plan would be for you. And I'd also like to follow up in about 30 days to see how your medicine is working.
I am so overwhelmed. So I have diabetes. I need to start new medication. That medication will have side effects. I need to exercise and I need an appointment with this nutrition person. I am really not sure how I can do all of these things at once.
Yes, I completely understand. And don't worry, we will work together to help you control your diabetes. So just as a follow-up, later that night at home, Sally tells her husband, the doctor says I have to stop eating sugar and start exercising more. I have to take medication for diabetes that will make me sick. And I have to start seeing a diabetes person at the clinic. I just don't know how I'll be able to manage all this stuff. So Crystal, if you could go to the next slide, please. We would like to get your feedback on what you thought went well in the conversation and what you think could have been improved. And if you could put that in chat. Okay, good. The provider helped the patient develop a realistic small goal to increase their physical activity. More encouraging language about diabetes being very manageable. Okay. Yep, somebody mentioned using teach back. Too much clinical language, so too much kind of technical stuff. I noted that as well. The provider started out saying hemoglobin A1C, and that's before she explained what was going on, or he or she. Patient was feeling overwhelmed, and maybe the provider didn't respond as well as they could. So just using more patient focused terms, giving her more time to really absorb the information. The provider didn't ask her what was most important for her to start with. They just said, do all this stuff at once. More patient-centered, absolutely. Awesome. Anybody else? I noted a couple things. They said in one instance, control instead of manage, which was something that we saw in the language kind of section. And just like a few people said, using more patient centered language as far as using too many technical terms that might make it even more overwhelming. Awesome. Okay, we're gonna try to do a poll here, and this is really so at the end of the scenario, we heard kind of what Sally took back home to her husband and how she was feeling. So I want to have you guys give us some input on what misconceptions you've heard from patients that are either, have diabetes or are newly diagnosed. And we're going to use a Menti poll. So if you could, Crystal, if you could let me share my screen, I'm going to pull that up. All right, are you guys seeing the website and the code?
Yep.
You should be able to put up to 3 answers in there. And then it will populate on the screen and we can see what everybody's misconceptions have been from their patients. This will be so easy. I like to see that. And then on the other extreme, death sentence. Too much sugar. Can't eat sugar. I've heard that one a lot. Shots, yep. Bad habits. So that can be something, if they have that perception, it can be something that might make them kind of have that stigma or that feeling of not being adequate in their health. I'm too fat. All right, good feedback, you guys. We've got one more question here. And I will save these and put them in the slide set before we send that out as well. So are there strategies or resources that you find helpful to help dispel these misconceptions or just explain or provide information to your patients that help clarify some of the things that they might be saying and feeling? Training session, so that's speaking well to that kind of gradual process of giving them little bits of information instead of throwing everything at them at once. Real life examples, written material, yep, so verbal and written, teach back, realistic goals, so that'd be working with the patient, find out what they're willing to give, patient-driven goals. Support groups, very important for behavior change. Common language, I like that. Listen and answer. Apps. Small goals. This is great. Thank you everyone for your feedback. All right, and I think Stevie is going to wrap us up.
Which screen can you see?
Currently nothing.
Okay.
Incorporating stories, I like that too.
How about now?
Perfect. So now I see patient
Yes, ma'am.
scenario. So if we can move ahead 2 slides, please, to the leaving and action slide, Crystal. Perfect.
Yep.
Wonderful. Well, thank you everybody for experimenting with our Menti polls with us. That's a new tool that we are experimenting with and just love it. It's a great way to really visualize the different ways that we can improve the care delivery we all provide. Our leaving in action today is really similar. And stick with me after I get off this slide because I need to ask you a bunch of questions about how this went. So as always, we want you to reflect, share something that you learned today with your care team. And then we really want you to focus on implementation. So take one new idea or tool that you learned here and try it in your practice, either from this session or previous sessions, things you've heard from your peers in the comments. And then last, we want you to really engage and remember to always meet patients where they are. For too long, we've really focused on compliance in diabetes care and getting patients to do what we as the healthcare team feel like they need to do. And we're not always thinking about the patient perspective. So we have this great opportunity to hit the refresh button clinically and think hard about what is most meaningful to patients so that we all can be on the same page. And then it winds up being a much more satisfying experience for us as the healthcare provider and for the patients so that we can work together toward those common goals. So we can move on to the next slide. And Mary, if you would please pull up our first poll. So today we're hoping that you can commit to quality and commit to doing something small in your practice as a result of these learning sessions. Please select all that apply. And if you happen to have something else you want to do that's not listed here, feel free to type it into chat for us. And Mary, for whatever reason, I can't see response rates today. So whenever you feel is a good time to wrap it up, feel free.
So Stevie, I can read the responses if you want.
Yeah, that'd be great. Thank you.
So it looks like the most folks were wanting continue more education, followed by access available data to identify quality improvement opportunities. Awesome.
Perfect. Thank you, everybody, for your feedback. And we can move on to the next slide. And if we could see the next poll, please. So we are curious what topics you might like more information, targeted quality improvement assistance, or facilitated peer sharing. Again, please select all that apply. And if you have other ideas that aren't listed here, feel free to type those in chat.
Mary, can you broadcast the results on that as well?
Yep, it looks like people are still responding. Okay, so leaders of the pack were diabetes prevention and cardiovascular risk reduction, We also have a comment from Allison in the chat that they'd like more information on kidney disease. Perfect. So we will go ahead and close that. And if we can move to the next slide and the next poll, please. There's just a couple more questions, so hang with us. So we're just curious about which format you preferred here and which length of time you preferred. So you'll choose one for each of those. As a quality improvement organization, we're always trying to improve internally as well. So these things help us to meet your needs better with next activities. We'll give that about 10 more seconds. Perfect, we can close that poll. Awesome. So it looks like people enjoyed these 60-minute sessions. I would not have expected that, so thank you for that feedback. We're happy that this was valuable use of your time. And people enjoyed all of our different versions, it looks like, but the interactive with time for question and answers was the leader. Perfect. Next slide and next poll, please. All right, we'd like to know how often you like to meet. If you can just choose one. We're curious here about frequency and was this enough, too much? All right, so it looks like this every 2 weeks was pretty well received, but perhaps monthly might be a better fit, or even moving to quarterly. And next slide, please. This is, I believe, our last poll here. So what topics would you be interested in hearing more about? I know that we asked you this about diabetes, but now this is going in a different direction. Do you want to know about infection control, emergency preparedness, immunizations? We've talked about kidney disease. What sounds like a good fit as we move into the new year? We'll give that just a couple more seconds. Right, so it looks like infection control and telehealth updates, but there seems to be good interest in all of these topics. So, thank you for that feedback. Let's go to our next slide, please. All right, with that, I'm going to pass things over to my colleague, Patty, who's going to talk to you about what things will look like as we move forward with Mountain Pacific.
Thank you, Stevie. First of all, I'd like to thank everyone who participated in the LANs around hypertension and diabetes. We really felt it was important to get the information out, especially with the overlap with COVID. So what happened was Mountain Pacific kind of took the reins and created these learning activity networks and these education opportunities because we really felt the need was there. What the next steps are going to be is we're really reaching out to our partners and other stakeholders to create a more collaborative chronic disease learning and action network. So that's really what's going to come next. And we're going to leverage the combined resources and expertise of those partners and stakeholders so we can bring in more people and more experts and more voices to the conversation. Really hoping to result in, of course, we'll do group education, but more peer-to-peer sharing, and really with spin-off, we're going to actively really spin off affinity groups to focus on specific quality improvement activities to help improve specific outcomes. And so it's really going to go from a didactic learning to much more interactive and much more activity as a result of the lands. And you can look at that coming in the first or second quarter of next year. So all of the information you provided us on all these polls will help us determine the topics and how we actually move forward with this. So if you have any interest in participation, any interest in participating in this or being part of the collaboration that helps form it, please let us know. So thank you, everyone.
And with that, we've got some time left, so we can open things up for question and answer. So if you have questions, feel free to take yourself off mute, or you can type them in chat. Okay, well, it sounds like there are no questions today. As always, you can reach us via email or phone at Mount Pacific. We appreciate everybody's participation and engagement, and we hope that you have a wonderful holiday season, and we will see you again in the new year, if not sooner.